Just going to introduce the team to you. We've got Vicky Brown, Rachel Cowley, Anna Doris and Amy Endicott helping us as a committee today, and this is your agenda for the day. So you've got Anna and Emma doing a presentation on the instrumental assessment across the patient pathway, so acute and community. I think that will be really interesting. We've got Jodie speaking to us about ultrasound, a useful addition to the dysphagia toolkit, question mark. And then we're going to finish a really interesting morning with Lee talking about functional esophagoscopy after FEES. And then we'll do the Q&A at the end, if that's okay. So we're going to save the questions for the very end. Unless something's urgent, please do let us know. But like I say, if we could respect our speakers and keep our mics off, that would be hugely appreciated. So if Anna and Emma are ready, I'm going to hand over to you. Please give us your presentation.
Thanks, Jodie. I'm just going to share my screen. So good morning, my name's Orna. I'm a speech therapist at UCLH, specialising in haematology. So this morning I'll be presenting with Emma, who works at the Neurological Rehab Centre at the Royal Free. So we're presenting a case study on the use of instrumental assessment across the patient pathway. So like Alexia said, joint, acute and community working. So to give you a bit of background first on this patient, he was a 46-year-old male who presented with classical Hodgkin lymphoma in 1994 and was successfully treated then, but unfortunately it relapsed in February 2020. He went on to have chemotherapy and an autologous stem cell transplant, which is essentially just using your own stem cells rather than a donor, to have a transplant in July 2021. Following his transplant, he unfortunately went on to have some post-transplant complications. And this kind of more or less happens because these patients are immunocompromised. And in April of this year, he was admitted to UCH with shingles, new onset of hearing loss in his right ear, photophobia. He also had a new right cranial nerve 7 palsy and dysphonia. ENT were asked to come and have a look, and they performed FNE with this patient and found that there was a right vocal cord palsy fixed in the paramedian position. The working diagnosis at the time was that this was a presentation of Ramsay-Hunt syndrome, again due to his compromised immune system. And he also had this ongoing vomiting and nausea. And they also had this working hypothesis of a herpes-like virus within his actual esophagus. And they tried to perform an OGD, but he was unable to tolerate the scope at the time, and so that was abandoned. So a couple of weeks after his admission to the hospital, he was referred to myself for his initial speech and language therapy assessment. And first assessment was very limited. He was in extreme pain, just global kind of body pain. He had this ongoing photophobia, and he had an NG tube in place, but due to this persistent nausea and vomiting, he was only tolerating the feed at about 20 or 30 mils an hour. So first assessment, we didn't get very far, and I advised on optimizing his pain medication and also liaising with the dietetics and the medical team about increasing his PPI, with the plan that I would return later in the week to see him. So he went on to have an MRI brain prior to my next review, and Essentially, the medics described this as an infection within his inner ear canal, which was causing his 7th and 8th cranial nerves to swell and also kind of respond to this internal infection. And that would account for his facial palsy. And so when I went to review him then on the 29th, we actually got to do an oromotor assessment. He was a little bit better from a photophobia perspective, and we had managed to get on top of his pain. So he had very mildly reduced bilateral lip seal, but he was quite dysphonic, moderately dysphonic, with breathiness and asthenia being the main characteristics. Surprisingly, he had no adverse signs with thin fluids and puree, but was reporting this ongoing globus sensation with both diet and fluids, and didn't really matter whether we tried, diet first or fluids first. It was kind of ongoing. So I recommended that he would continue just having 0 and 4 small amounts alongside the NG. And I kind of took a bit of a watch and wait approach. Just generally, he was someone who just kind of felt like he needed some time to get better. They had started him on some antiviral medication and also gave him some dexamethasone as a treatment for this swelling. For the internal swelling. But the issues with the NG tube and the rate of feed kind of still persisted, and he was having these ongoing hiccups as well. So I was just kind of distant monitoring him and checking in and out with him, but he was very keen to just continue having very small amounts. So as the classic story goes, it was the 13th, and it was actually a Friday afternoon when his chest then suddenly deteriorated, and they thought at the time that he had aspirated on some soup. The following day, not quite sure why, but he had an OGD to check out. Essentially, I think they were querying whether he was getting some potential blockage or some bottom-up aspiration as well. But the OGD was relatively normal and just showed some mild gastritis. Following the OGD, though, he required high-flow nasal cannula treatment and was admitted to ICU for some close monitoring. I went to see him then on the following Monday, and his assessment remained very much unchanged. He was still reporting this globus sensation. His cranial nerve exam was still pretty much the same, but he just had one episode of desaturation with level 0 fluids, which he quickly recovered from. The patient at this time was becoming increasingly more frustrated, though, I guess, with all of these issues that seem to have just, I think, in his mind, come from having this transplant and having this weakened immune system as well. So I went back to the drawing board and I just kind of looked at him in a little bit more kind of detail and just thought things just aren't adding up with him. And I guess the kind of biggest worry in my mind was that there may have been a relapse of the lymphoma, particularly in the CNS, and whether, this was just kind of a bit of a red herring, the infection, and potentially there may have been a further CNS relapse with him. So these were my 4 main decision makers in terms of whether I should continue and perform an instrumental. And at the time, a video was the only instrumental available to me. I think there was definitely argument for either a video or a FEES with him, but I think the VF would have been the correct choice anyway. I think just given his kind of reports of this globus sensation as well. We got to see a good bit of the esophageal stage as well. So we proceeded with the video fluoroscopy, and these are some of the main images from the VF. So yes, I think the most, it is important to say that yes, there was aspiration and you can see that, but there wasn't huge amounts. And I was actually more concerned about what was happening or what wasn't happening from a pharyngeal perspective. And that's to say that his oral stage was more or less NAD. So he had, his main impairments were lack of epiglottic deflection, no laryngeal vestibule closure, and his pharyngeal stripping wave and opening of his UES just were completely diminished. He had severe residue with thin level 1 and level 4. It was bilateral, but more diffuse on the right. And again, yes, there was aspiration, but that wasn't my primary concern. And I guess looking at him as well, now that I had more information from the video and using the video to kind of link back to a cranial nerve perspective, it was standing out like a sore thumb that cranial nerve 9 was majorly impaired. But the evidence for that from his MRI just wasn't really adding up either. So what to do next? So yeah, as I said, it's more than just aspiration that I saw and that I was worried about. So I went back to the hematology consultant and the neurologist. And again, another kind of twist in the story is that it actually turned out that they had a neurology MDT about this patient. And when they reviewed the MRI in closer detail, what was missing from the final report was that they also saw that cranial nerve 9 was also swollen along with 7 and 8. So eventually he actually made a little bit more sense. And another important thing to point out is that they were very confident that this was the only cause of it, and that there wasn't any CNS relapse. Nothing had shown on the MRI, and he had also had a lumbar, a bone marrow aspirate as well to rule that out. So speaking with the patient, he was extremely low in mood, and again reiterated that these were kind of essentially problems that had come from him being cancer-free. So talking with the neurologists and the hematologist as well, the jury was very much out in terms of the prognosis for nerve recovery. So either full recovery, length of recovery. But I did have that conversation with them about, well, not only time being the healer, but was there anything to contraindicate myself starting some dysphagia rehab with him? Because I very much think, well, use it or lose it. And also, if there's nothing to contraindicate using some dysphagia rehab, then why not? So they gave me the green light to go ahead, and we started him with modified Shakir because he was on a very long 18-hour feed due to these issues still with reflux and nausea as well. That was later changed to an NJ, so he was able to go back to doing regular Shakir. We started Misako, and we also started some Laxvox with him as well. And again, this is kind of where to showcase that this was a patient who was transferring now to the community with an NJ and passing him over to Emma for ongoing rehab. So I'll pass over to you now, Emma.
Thanks, Lorna. So yeah, just to explain, so I'm based at the Neurological Rehab Centre, and we have both an inpatient neuro rehab service and a community neuro rehab service as well. So When we first got this patient's referral, his aspiration pneumonia and him being in intensive care was only a few weeks prior. So we were very apprehensive about whether we could manage this patient safely in the community. And we did have discussions with our inpatient team about whether he would be more appropriate for them. They were happy to accept him, just focusing on swallow rehab. He was a bit of an unusual presentation for us. We're not used to seeing patients in the community with NGs or NJs. Similarly, our inpatient unit don't normally take patients with NGs or NJs. But obviously, we looking at everything that we had, we felt like he was safe to manage in the community. We just definitely didn't want to start any oral trials yet. That was also helpful to liaise with Orna at the time, because it was one thing reading all this referral information and reading a patient's video fluoroscopy, but getting on the phone and chatting to Orna, who has seen the patient, it really helped me to build up an image of the patient in my mind. That's something we'll reflect on at the end as well. So we continued with the swallow rehab. The plan was to do, roughly 4 to 6 weeks. Again, our neurologists on our side weren't able to provide any more certainty about what we could hope to expect regarding the cranial nerve prognosis. So we really didn't know what we were working with this patient. So and he hadn't been engaging too much because Orna mentioned the low mood and he had various other things going on. The engagement was tricky. The motivation was there, but it just felt like he had so many barriers in the way to achieving what we wanted in therapy. So the plan was to just really go hard with intensive swallow rehab, the Shakir, which in the end, through working with a dietitian, we were able to modify his feed a bit, so he could come off the feed and then do the full version of the Shakir lying down, the Masako and Laxvox as well. And after discussion with Bette Kimber as well at Queen Square, I decided to go ahead and do some oral trials of sterile water only. His oral care was really good, with an effortful swallow. So it was then, if we go the next slide. So then decision comes to think about repeating an instrumental. This was now a couple of months after he'd been discharged from acute, and he'd done about 6 weeks of swallow rehab exercises. So the main decisions here about doing an instrumental was, we had this complete lack of certainty about what we could expect. I was hoping after 6 weeks of swallow rehab, we might see some improvement. He had made gains as well in other aspects. So his mobility had improved, his fatigue had improved. And from his perspective, his dysphonia had improved as well. So I was really hoping that the swallow would be following the same trajectory of every other aspect. Essentially, I needed information about how to plan the next steps of intervention. So, i.e., was there enough potential here to start oral trials? And I wanted to give the patient some biofeedback as well, because he had significant trauma about the aspiration and him ending up in intensive care. So there was a lot going on, and I wanted the biofeedback to be able to, I hoped that I could physically show him an image of, look, you're not aspirating. That was the dream. So we did go ahead and do a video fluoroscopy. Next slide, thank you. We trialed thin fluids, custard and banana. He did aspirate on the first bolus of thin fluids, but on other boluses there was no aspiration, and once we used the strategies of effortful swallow and 3-second prep as well, and those were effective. The custard and the banana, if we go to the next slide, again, it's just this same picture of the residue and the difficulty clearing. So, we saw the reduced pharyngeal contraction, the reduced laryngeal excursion, the epiglottic deflection was still completely absent, and significantly reduced UES opening. So, as you can see, the majority of the bolus stayed above the level of the UES, and he needed multiple swallows to transfer trace amounts through the UES. And when I say multiple swallows, I'm talking, 10 to 15 clearing swallows. He was able to reduce the amount of residue, and he was able to clear. The frank aspiration on thin fluids, we weren't too worried about, because once we started using the compensatory strategies, it was effective. He did have a prompt cough response to the aspiration, although it wasn't effective in clearing the aspirated material. But essentially, if we go to the next slide, I did feel that there was enough potential here to start safely on oral trial. So I took a McNeil type approach. We started, we were aiming for 1 hour of therapy a day, and he was having the level 0 and the banana and the puree, very, very small amounts to start with, teaspoon, and the plan was to build it up to tablespoon amounts and increasingly. So we ended up doing about 7 weeks of oral trials. This was a bit longer than I'd anticipated because of all the challenges we had to therapy. So I mentioned some earlier. He was really traumatized by his whole experience, really not in a good place in terms of his mood, really just having a hard time accepting, you know, what was happening to him. He used to be a sound engineer. He'd lost his hearing in his right ear. He was told that he was never going to get that back. He didn't know what the prognosis was, his swallow. Neither did any of us. He was suffering from fatigue and general mental overload. He had appointments coming out of his ears. And he had social issues as well. So there was a lot going on, and practical issues as well, like the length of feeds. As Orna said, it was 18 hours initially. We did manage to reduce that, but by the time he woke up in the morning, took his medications, did all the flushes, it was already 11 a.m., 11:30, late morning. So he had trouble committing to setting time aside to do the swallow trials. He also, just at his baseline, wasn't the kind of person who sat down and ate 3 meals a day. So that was a useful reflection for myself as well. It's thinking about, you know, what can I expect with, you expect patients to be so motivated by oral trials, but if they're not the massive foodie beforehand, that might be a barrier. So I referred him to the neuropsychologist in our team. I referred him to OTs and rehab assistants for fatigue management, did lots of joint session and joint working with a dietitian as well. And in terms of future planning for when we might have to reduce the feed, and also in terms of having time to do the exercises and the oral trials. And I also tried changing the timing and changing the environment of our appointments. You know, one time I went to his house instead of him coming in as an outpatient, and, you know, organised for the wife and him to have lots of food spread out to have a meal. And they said, oh, this is the first time we've had food on our table in a long time. So tried lots of different things to kind of get him to engage, essentially. Also, just one thing to add, his chest had been stable that whole time as well, that before we decided to commence oral trials. So, and from the videofluoroscopy, I felt like there was enough potential. So another issue that this patient had was his voice. So he still presented with this moderate dysphonia. It was moderately rough, mildly breathy and asthenic and strained. And once I did the VHI on him, it did kind of come to light a bit more that it did have a significant impact on aspects of his daily life, the functional, social and emotional aspects of his life. So that was something else that he was kind of battling with. And he was also really bothered by this coughing, and it wasn't related to the oral trials. It was just throughout the day, more so at night when lying down. He couldn't sleep next to his wife anymore. He always had to move downstairs. He was hypersensate to everything in his throat. He kept on talking about the sensation of sandpaper at the back of his throat. So all of these things kind of combined helped me making my decision about the next instrumental assessment. If we go to the next slide. So it was time to perform another instrumental. He'd been doing the oral trials now for a while. And my rationale for choosing a FEES over videofluoroscopy was I wanted to kind of check back in with the vocal cord pathology, see if there was any improvement there with the right vocal cord palsy. There were no oral concerns, so I didn't feel like I was sacrificing or compromising on anything by doing the FEES instead of the videofluoroscopy. I wanted to have a look at his secretions as well, just because of all the hypersensation he had, and I also wanted to try and vary the biofeedback he was getting to kind of just help to reinforce this image of, you know, everything's looking okay there. I know you might be feeling things, but it's nothing of concern. At this point, he was managing mostly level 5 minced and moist and increasingly small amounts of level 7 easy to chew and thin fluids. So we did the fees. It showed still a right vocal cord palsy and the contralateral cord, that it was incomplete compensation. This is the New Zealand secretion scale, and if we go to the next slide, you'll see the PAS scores. So we tried level 0, level 3, level 4, and level 6. And again, just this picture of the severe pharyngeal dysphagia because of the pharyngeal contraction, so resulting in this significant diffuse amount of post-swallow residue, which wasn't cleared with a liquid wash or effortful swallow, which again was nothing really new to me. I knew that he had this picture of, you know, significant residues, and it was just about multiple swallows. The residue overspilled into the laryngeal vestibule, and they did see trace chronic penetration and aspiration, which they said the patient wasn't sensate to. The patient argued against this, saying that he was sensate to it and he was aware of it, but he didn't respond because he's just so used to it now that he just doesn't respond to it. But a prompted cough was effective in clearing the material, so you can see there from the PAS scores. So after the fees, it was a bit of a step back. It was a bit disappointing and not the outcome we had been hoping for. But after discussion with the patient, you know, I kind of explained to him that he had been able to maintain a clear chest status at this point for over 3 months. So although there was kind of a history of anxiety about aspiration, he did understand that it didn't really impact anything and it didn't have to change what our intervention was. He wasn't going to stop eating and drinking at this point. He made that very clear to me, even if I would have wanted to take a more cautious approach. So, you know, we didn't really let the fees change anything. It wasn't what we had hoped, but it didn't tell us that much different to what we knew in terms of the residues. And he was obviously tolerating the aspiration. It wasn't our biggest concern. So, and as we know, dysphagia on its own isn't the biggest predictor, and he had other protective factors. So the future plan for this patient was just ongoing swallow rehab. The plan was to work really closely with a dietitian. We were really close to getting to the point where we could remove the NJ, but he actually went ahead and did that himself just a couple of weeks ago. He was on holiday and he was really enjoying all the food and he just wanted to remove it, so he did that. He then had some neuropsychology inputs just a week or so ago, which he's found really, really beneficial. And we're just going to continue working together to increase the amount. He's still having some ensures to supplement his nutritional requirements, but working closely with a dietitian, we're regularly weighing him and gradually increasing the amount that he's having orally. And the hope is that we should be able to discharge him at some point. But we also want to think about him returning back to work. We have a vocational rehab therapist in our team, so she will be involved as well. So he's not going to completely leave our team anytime soon. So Orna and I were discussing kind of the key take-home messages. Essentially, the cross-site acute and community working was really something to reflect on, because like I said, it's very, very different just reading a referral, and just jumping on the phone to speak to Orna was really helpful for me, and I could build up an image of this patient in my head. And then also just utilizing that throughout the journey with the patient. You know, there were a couple of times I got on the phone to Orna as well, and it's just useful to have that person to kind of bounce ideas off. And again, looking at the patient holistically and just remembering that these instrumental assessments are just a snapshot in time. You know, it was interesting that the fees showed that he was aspirating, that he wasn't sensate to it, but a promptive cough was effective, whereas the videofoscopy showed that he was sensate, but a promptive cough was not effective. So just kind of taking a step back and remembering to look at the patient holistically, and thinking as well, if your instrumental assessment does show aspiration, would your management change? Orna and I have discussed that if I would have chosen to do a fees as my first instrumental assessment, you know, like a few weeks after he came out of hospital and I would have seen that picture that we saw in the fees, would I have felt that there was enough potential there to do oral trials? I'm not sure. I think I would have been a bit too nervous, considering it'd only been a few weeks since his aspiration pneumonia. So it's just kind of taking a step back and thinking, will your management change if it shows aspiration? And again, linking in with the pathologies that we're seeing, the cranial nerve injuries that we're seeing, and just making sure that it all adds up with what you're seeing on your instrumental assessment. Don't know if you have anything else to add, Orna, about our take-home messages.
No, for me, it really is that linking off your cranial nerves, and then, yeah, if they don't make any sense to you at all, just think about really like what you're seeing, and yeah, just think about what the goal of your instrumental assessment is, really.
Well, thank you both. I think that was an excellent presentation and a great way to kick off this then. Really interesting case study, and really I love the fact that we've talked about the patient journey. It's not just acute focused or community focused, it's actually about the seamless journey for the patient throughout. As per the beginning of the talk, we're going to do all questions at the end, and I know Jodie's already posted something and I've had some separately, so we will be asking them, so please don't go anywhere unless you're in an urgent rush, and then come back at the end. But yeah, we're going to carry on with our next speaker, who is Jodie Allen, who is joining us to talk about ultrasound this morning, and whether it's a useful tool in the arsenal of speech therapy. Jodie, over to you.
Hello, hi. I'm just going to load my slides, which I've just realised match my top beautifully. That's a cool thing to do, isn't it? Let's share my slides. So I've tried to make this emphasis on the tried a little bit interactive, because these sorts of kind of online events are a little bit challenging to get any sort of discussion going. So I'm going to kick off from the get-go with I'm going to try and kick off from the get-go with a Mentimeter. So get your phones ready, and ask you, before you've even heard anything about my presentation today, about what you think about the ability of ultrasound to form a useful addition to the Dysphagia Toolkit. So your options, there's your QR code. Hopefully it links you to the Mentimeter. Well, there's the link. Your options are you serious? Persuade me. I can see where this might go. Or I'm sold. So if you pop your responses on, hopefully most people can get on. Shout if you can't, because I can't see anybody. Then I have to do something clever about pausing these slides and getting Mentimeter up. Fabulous. Can you guys see that screen that I've just switched my sharing to? Hopefully I can see it beautifully. So most people are somewhere between persuade me and I can see where this might go. So that's reassuring. And 2 people are sold. That's exciting. Who are those people? Let's get them talking to us, which is fabulous. I know there's some sonographers joining us today as well, so it'd be really interesting to hear your views as we move through. So keep voting if you haven't had the opportunity to vote, because we're going to come back to the same question at the end of the next 40 minutes or so. Okay, so I'm going to share, let me get rid of these slides now. I'm going to share my journey, my emotional journey with ultrasound, so you know where I am at before I start telling you a little bit more about ultrasound. So my first response to thinking about ultrasound as a tool in dysphagia was, are you serious? Why do we need ultrasound when we've got FEES, we've got video fluoroscopy? What more is ultrasound going to tell us? So I started very much at the, are you serious? But I took it seriously enough to want to explore it a little bit further. And you may or may not have seen our rapid review that we did essentially at the start of COVID, because that's when we started talking about ultrasound as an alternative possible tool that doesn't generate aerosol. So we did a rapid review to see whether that "are you serious? Convince me" is possible. And actually I came away from that rapid review feeling I needed a hell of a lot more convincing. I needed more evidence that this was something worth pursuing, because yes, there was actually some evidence to support its use as a tool to identify vocal fold impairment in post-surgical populations, but I wasn't convinced at all really by its ability to be used as a tool to assess dysphagia. But we were thinking very much about assessment at that point rather than anything else. We weren't thinking about therapy or biofeedback. So I was still to be convinced, but as a group, we decided to think a little bit more pragmatically and as clinicians rather than researchers. And then we generated a narrative which asks a very similar question to the one I'm asking you guys today, except the focus was purely on assessment rather than anything else. So we generated a narrative which was about the position of ultrasound as it stood in speech and language therapy as a dysphagia assessment tool. And after that, I felt a little bit more positive about its potential utility. And I started feeling like I could see where this might go. And then in order to work out where it might go, we spent some time developing a consensus statement. So it was the International Ultrasound Group generated recommendations for what we needed to do in our profession to take ultrasound to the next level. And I'm going to share those results with you very briefly. But once we generated a list of recommendations and had a much more tangible idea of where ultrasound needed to go and what we needed to do to bring it into our dysphagia assessment toolkit, I felt a little bit more like I'm in. Okay, I'm in. I know where we're going. I know what the evidence is. I think this is something that we can achieve. So this paper is online in Dysphagia at the moment. It's not been published in the actual journal. But you don't need to absorb any of this. But just to give you an idea of the sorts of things that we ranked and prioritised as needing to focus on if we were going to use ultrasound as an assessment tool, we looked at we're starting to look at these top 5 items, top 6 items, and really reassuring. Having gone to ESSD a few weeks ago, I was really reassured to see that actually a lot of this work is going on across the globe, really, looking at the reliability, the validity of ultrasound, what normal looks like, how we're going to train our speech and language therapists. So I was really reassured, and it's nice to know that we're working together towards achieving these goals. So, in fact, we then got so convinced of its utility, we started thinking about training the workforce. And actually what we've done now is develop a document, a framework for use of ultrasound by speech and language therapists just in the UK, because that's currently where the major clinical momentum is. And it's a document that's been produced for adult and paediatric speech and language therapists across dysphagia, but also speech and voice. So it's a coverall document. And we did that deliberately because we wanted to unite pediatrics and adults. We wanted to unite speech, swallowing and voice as well. So we're hoping that we can launch that and use that as a framework to start helping speech and language therapists train in ultrasound in the near future. But it's all well and good training people if they don't really know why they're training and what the goal is within our field. So I'm going to share some of the evidence with you this afternoon. No, is it this afternoon? Probably is now. And just get a sense of where you guys are at the end of this. So within our framework, we have divvied up ultrasound into 3 kind of subcategories. So we can use its application for static imaging, whereby we put the ultrasound probe on the head and neck and we don't move it, we just look at static structures. We can use it for qualitative evaluation, so that is looking at dynamic imaging. So movement, but we're not measuring the movement. So we might be looking for presence or absence of movement, for example, but we're not looking at quantifying that movement. And we can also use it for quantitative assessment. So that's when you're looking again at dynamic movement. You might be looking at movement of the tongue, for example, but you're measuring it and you're making actual measurements about range of movement. So we've divided them into 3 of these categories for pediatrics and adults across speech, voice and swallowing. So this is the FEAS-VF then. So I'm focusing purely on dysphagia today. And I'm going to talk you through some of the applications that it can be used in and some of the evidence for using it as a static imaging tool within speech and language therapy. So what we do know ultrasound can do is look at head and neck anatomy really quite well. The limitations, of course, is that it can't penetrate very, very, very deep. So we can tend to only look at relatively surface structures. However, we can get as far as the vocal folds and the posterior larynx to the posterior pharynx as well. So we know that we can look at the orofacial muscle, so we can look at the external muscles involved in speech, voice, swallowing. We can look at our salivary glands very easily. That's something head and neck sonographers do all the time to look for things like lesions or shrinkage. We can look at the trachea diameter, we think, and there's a school of thought and there's a small amount of new evidence to suggest that ultrasound can also see bolus material in the pharynx. I'm yet to be convinced of that one, but there are papers out there that suggest it's possible. And looking at that head and neck anatomy, we can choose to look at the size of it, we could choose to look at the structure of it, and we might choose to look at the location of it, because interestingly enough, it's not all standardly located in every human's body, and you have to search for it sometimes. And with that information, we could use that to educate. I've certainly been highly educated in the muscles of the head and neck in my training in the last few years. Education and training for speech therapists, to be speech therapists, anybody who's interested in head and neck anatomy. You might use it for assessment purposes, and I'll show you how, and we might use it for treatment purposes. So let me show you. So thinking about the orofacial muscles, so these are the muscles that we tend to look at. I'm particularly excited about this because this is my patient group are neuromuscular, and they tend to have, they have muscle disease. So we're looking directly at the muscle. And so these are the muscles that we can look at definitely with ultrasound. We can look at the muscles of the floor and mouth, so the anterior belly digastric. I don't know about you guys, but when I was at university, I used to learn about the anterior belly digastric. I used to know what it did, never saw it, but I've seen it now on ultrasound, and I've got a much better grasp of where it is, what it does, how it looks, as well as the geniohyoid muscle. You can also look at the masseter or masseter. I always get told off for saying it wrong, temporalis, and the tongue muscles. So from an education perspective, if you haven't seen ultrasound before, or floor of mouth ultrasound before, which I suspect many people haven't, this was a bit of an eye-opener for me. So this is essentially putting a probe. In fact, I'll show you the next pictures. Might be a little bit clearer for you guys, but this black box here is where we would put the ultrasound probe across the jawline. I'm going to show you a picture of me putting the probe on. So what you're getting is ultrasound from the floor of mouth up into my oral cavity, which translates, these are my anterior belly digastric. You saw it here first. So what you're seeing here are the anterior belly digastric muscles, 2, left and right, the mylohyoid muscle, which wraps around the jaw, and then the geniohyoid muscle. So that's an internal view of basically sticking the probe just there under your chin. And hey, that opened my eyes when I did that for the first time. What an education. That's great to show you what they look like, helps you maybe understand their function a little bit. One of the really exciting things, I think, about ultrasound and looking at the muscles is that it tells you how healthy they are. So the team over in the Netherlands have really been pioneering this work. And this muscle you can see on the left-hand side is the probe over the jawline. So it's looking at the masseter. And that's a healthy masseter. Now, when you study anything with disease, the muscle looks different. And if the muscle is atrophied or it's got fat in it, then it starts to look brighter and grayer, and you can probably see that quite obviously in those two images. Now, we're neurophysiologists, so using things like ultrasound as biomarkers, so early markers for changes in bulbar function. So it might be that we see changes in the muscle on ultrasound before we see changes clinically, so before we see problems with chewing, for example. And they are using ultrasound to look at whether there is underlying muscle pathology. And I'm sure all of you out there have had that conversation about, are these muscles weak, or are we training rigidity because it's Parkinson's? Are we training spasticity? And actually, isn't it wonderful that we could potentially put a probe on some of those muscles and understand whether there is atrophy to cause weakness, or whether actually we're looking at a very normal, healthy underlying muscle. And the Netherlands team have made our job, or starting to make our job a hell of a lot easier. Because when you look at greying images, black muscle is healthy, more grey is less healthy, and even greyer is really, really not healthy. And you used to have to do grayscale analysis. So basically you feed it into a processor and it tells you how grey the image is. I mean, that's a bit of a faff, isn't it, if you're a frontline clinician? So they've developed a visual scale whereby you judge by eye. So you're looking at normal, abnormal / uncertain level of muscle degradation and abnormal. So they've developed a clinical tool that we don't have to then process images, for example. And for me, that's really, really exciting. It might tell us a little bit more about what we're trying to treat. The other thing is, and I don't know if anyone's seen this paper, it was published this year, whereby people have used ultrasound to evaluate the impact of their treatment. So really still as an assessment tool, but as a tool to measure outcomes. So this group of patients, healthy individuals, had EMST, which I'm sure we're all familiar with by now, but for those who aren't, it's expiratory muscle strength training. So you're blowing into a trainer with the aim of strengthening the suprahyoid muscles. Now, in our EMST trial, we don't use ultrasound as an outcome measure. We use other things like video fluoroscopy, so we assess swallowing function. But isn't it great that actually they're starting to use ultrasound to assess the impact that strength training is having on the muscle? So this group of researchers conducted 5 weeks of EMST at maximum expiratory strength, and they found that the geniohyoid muscle, so this image is now upside down compared to the one you saw a few slides ago. So this is still the floor of mouth. And this is the geniohyoid muscle, so that's the one that's between the jaw and the hyoid. And after EMST, this muscle got bigger. So we saw that EMST trained the size of the muscle. So you could see the impact of EMST directly on the muscle, as well as, or potentially as well as, functional swallowing like video fluoroscopy and cough peak flow. So that's kind of a summary, a whistle-stop tour of muscle ultrasound. The other really, well, it's not a novel application at all, but it's perhaps novel for speech and language therapy, is that we know that Botox or Xeomin became licensed as a treatment for salivary gland sialorrhea, so injecting into the salivary glands. And we at Queen Square are looking at advancing kind of scope of practice for speech therapists by training them to inject into the salivary glands. And one of the things that you can use ultrasound for, in fact, it's recommended to locate the salivary glands, is ultrasound. So you pop the probe, a static probe, it's a static image. You look for the salivary glands, which look a bit moosey compared to muscle. If you compare these images, so the muscles here are black and a little bit stripy with white tissue running through. The salivary glands look moosey. So you can locate the salivary gland to know that you're injecting the Botox into the right area anatomically, because people's salivary glands vary in shape and exactly where they're located. I put spot the deliberate mistake here. I don't know if anyone's spotted it, but essentially the chap here is, we're looking at the parotid gland. just behind his ear, and I've not shown you any parotid gland. So these images don't link up with this image at all. So this is the submandibular, so under the jaw, and these are the sublingual under the tongue. And we don't inject these ones anyway, but it's just for the point of showing you what it looks like. And then just a kind of nod to the additional areas that people are looking at. So Helen Newman's a speech and language therapist doing her PhD at the moment. She's looking at ultrasound, using ultrasound to measure tracheal diameter for the purpose of choosing tracheostomy size. And like I said before, people particularly over in Japan are looking at whether ultrasound can be used as an indicator or to measure bolus residue in the pharynx. So moving into from static evaluation to qualitative evaluation, I'm going to talk you through, just give you a couple of examples here on how we might use it or can apply it to qualitatively evaluate our interventions, or even use it as an assessment tool. So the classic things, or the ones that we're seeing in the literature whereby qualitative evaluation has been used for vocal fold movement and perhaps swallowing manoeuvres. So we're basically looking at presence versus absence of movement, or perhaps position or timing, but on a qualitative scale rather than measuring. And again, they're being used for education and assessment, and as well as treatment. So have a little look at these. You may have seen this before. So here's an example of ultrasound application as a qualitative assessment tool. So this is vocal fold movement. So hopefully you can see here the thyroid cartilage. It looks a little bit like when you're doing a FEES. So you've got the thyroid cartilage and the vocal folds sit here, and your ultrasound probe would be up here on the surface of the skin. So this image is from Tim Beale's paper, who's a radiographer over at UCLH, and he's got a beautiful image, as have we. I just haven't had time to upload them, of how ultrasound can show you vocal fold movement. And even if you haven't seen a laryngeal ultrasound before, you can hopefully see here that the vocal folds left, right are moving bilaterally. They come together in the middle to form that bright white line, and then they abduct as the patient breathes out. And there you go. So that's a qualitative assessment. Is the movement there? Is it not? Yes, left and right, both moving, bilateral movement. Give you an example of a cord palsy now, where hopefully you can appreciate, even though the image is not perfect, you can see that the left cord over here is moving as the patient's breathing, and the right cord is doing very little. So qualitatively, you can say that this patient looks like they've got a right vocal cord palsy, but we're not quantifying where it's positioned. We're not measuring anything. But it's a present or absent decision, and ultrasound has been able to help us make that decision. So an example more about swallowing here. Ultrasound's being used as a tool to aid biofeedback for swallowing manoeuvres. So this paper is worth looking up. Again, it's new. There's quite a lot of ultrasound literature really coming up in the last few years. So this again is a team over in Japan, and they've used ultrasound to help people improve their adoption of the Mendelssohn. So essentially they've popped a curvy probe under the patient's chin, or the person's chin, and on this image here, so you can see here, that's the surface of the tongue. Probably looks like a magic eye for people who don't look at ultrasounds much, but it soon comes to you. Surface of the tongue, and this here is the image, the shadow of the hyoid bone. So this black image, bone always casts the shadow. So basically they've put the probe under the chin so that you can see where the hyoid bone is. And then instead of, so they essentially had two groups. One was using SEMG, where they pop the electrodes on, and one was using ultrasound. So for the SEMG group, for those that use it or those that don't, basically what you're looking at is sustained muscle activation. So you get the patient to swallow, and you try and get them to keep the activation high as high as possible for as long as possible. So they train on SEMG to get adopt the Mendelssohn maneuver. The other way of doing it, or the way that this team did it, the other arm did it with ultrasound. Now I have to apologise, this isn't the best image because I recorded it on my phone. But if I show you this image here, on the right hand side here, you can see, hopefully see the shadow of the hyoid just here, bobbing forward. So each time the patient swallows, the hyoid moves forward. Hopefully you can see that. And basically, this is a normal swallow, but what the researchers were doing was when training the patient to look at when the hyoid got to as forward as possible, and then they train the patient to hold the hyoid here for as long as possible, and then release it. So 2 different ways of biofeedback, and they found that the patient group trained on ultrasound adopted the Mendelssohn maneuver better. So there's emerging evidence for its use as a tool as a biofeedback, and but it was a very small group, and it also was in healthy individuals, so we don't know how useful it is to people with dysphagia, but hopefully you can get a sense of how it can be used to train a patient if you show them the landmarks. Okay, so category 3 is quantitative assessment. So we are looking at things like tongue movement, hyoid movement, thyrohyoid movement, movement of the posterior pharyngeal wall, which I am absolutely rubbish at trying to view. Some people can. Opening of the upper esophageal segment, again, not something that I'm particularly good at, and also vocal fold movement. So we're moving from making a kind of binary judgment, present or absent, or hold it a bit higher for longer judgment, to actually physically measuring. And we can use that, and this is really where the literature is still emerging. I'm yet to be convinced of its use as an assessment or screening tool. I think I need to see some more evidence to suggest that it's possible. So some of the research to date are suggesting it can be used as a screening or an assessment tool by essentially looking at cutoffs for movement in the swallowing. So one example of that is hyoid bone movement. So this one's usually looked at most commonly, and I think it's because you can probably see it the easiest, if I'm completely honest. And they pop the ultrasound under the chin. Again, they put it lengthways, chin to hyoid, and you can get a really lovely view of the geniohyoid moving left to right rather than front to back, which is what we saw right at the beginning. And people are actually measuring the distance, or the proportion of the distance that the hyoid is moving. So let me show you. So this is, I've turned it. The other thing is, if you haven't seen ultrasound before, is that when you put the probe on, everything looks upside down and you have to turn your head round when you first start learning. So I found it easier to flip the images. So I flipped this one round so you can see what it looks like. And so you guys can then hopefully appreciate how easy it is to see the geniohyoid on these images. So the probe is underneath the chin. The black over here is the shadow of the mandible because bone casts a shadow. The hyoid is over this side, casting a shadow, and the geniohyoid muscle spans the length between the mandible and the hyoid. And it's quite easy to see the geniohyoid because a healthy geniohyoid, in fact, even in very dysphagic individuals, the geniohyoid, I'm told, remains quite black. It's quite difficult to get a completely, whited out geniohyoid muscle. And above the geniohyoid, if we zoomed out, this is the tongue up here. So this is what researchers are looking at, this travelling distance of the hyoid towards the mandible. And this is it in action. So you can see the hyoid coming in from the right, and this side remaining very static at the mandible. And hopefully, even if you haven't seen ultrasound before, you can appreciate start to appreciate those structures and how they're moving, and how that kind of fits with what we see on a clinical assessment and a video fluoroscopy. So what the researchers are doing, if I can get onto the next slide, likes to play. Let me move on, please. Here we go. This is basically a static image of that moving one before. So they're looking at the distance there is at rest in a dysphagic or a healthy individual, and how far it moves towards the mandible, and then they calculate the relationship between the two, like the percentage distance travelled. And so some of the research is showing that actually in people with, well, they've correlated the distance the hyoid moves with whether they aspirate and whether they have residues. So this paper is quite old, really, in the ultrasound world now, is 2016. They looked at hyoid bone displacement, so this middle line, the non-aspirators, so how far the hyoid moves in people who don't aspirate compared to people who penetrate, compared to people who aspirate. And you can see there that there's a relationship between the three. So the non-aspirators, the hyoid bone moved furthest, penetrators less far, aspirators less far. So you could start to appreciate how it could be used to rule in out aspiration penetrators potentially with some more study. This was when they looked at the association between hyoid bone displacement and residue. So you can see that those without any residue in the piriforms, the hyoid bone travelled the furthest. Those with grade 1 residue, I haven't written the key here, but small amounts of residue, it travels slightly less far, and then more residue doesn't travel far at all. And again, there was a statistically significant relationship between those. So hopefully that just helps you appreciate how it could be used. And for me, it's really tricky. I think the reason the literature hasn't moved on with this aspect is that when you stick a probe under someone's chin, it's very easy to move the probe around and slip. And actually that degree of movement by moving the probe around will skew all of your results, because you move the probe and actually it wasn't the hyoid that's moving. So this is why dynamic ultrasound is a lot more tricky. And I would encourage you, if you are interested in this as an assessment tool, have a look at the Queen Margaret University team. So this is Gemma, one of the PhD students up there, and they've created a headset. This is a research headset, so it looks a lot busier than the clinical headset, because actually they put a camera here as well. And the headset is designed to stabilize the probe under the chin, so it's not the person doing it that creates the movement, it's only the swallowing movement. And a very clever engineer that works up there, Alan Wrench, and again his work's really helpful and beautiful contribution to speech and language therapy work, has developed or is training a machine to auto track. I mean, how great is that for clinicians? Because if the machine does the tracking for you and the measuring, it makes our lives a hell of a lot easier again, because we don't then have to pull our images and start measuring things. So let me show you this in action. So this is just to help you all out. This is back to front again. So we've got the mandible on the right hand side this time. We've got the genioglossus across the bottom and the hyoid on the left, and the hyoid, as the patient swallows, is moving in and shortening the geniohyoid. And if you look at the blue line, that blue line beautifully tracks that hyoid movement. It's quite stable. And so then the machine is telling you the distance it's traveling. So if you're using it as a screening tool, you pop the headset on, tells you that information. They're still training the tongue. You can see that that's jumping around quite a bit. So they're still training the machine to track the tongue for anterior, posterior stripping. But hopefully you can see that those kind of innovations and support from engineers are really going to help advance its use. So I've kind of come to the end of that third category and given you some insights into how ultrasound might be used in our profession as a static imaging tool. And I think it's already being used as a static imaging tool. It's in clinical practice, so it's being used in the UK to detect salivary glands, maybe not necessarily at this point by speech and language therapists, and it's certainly being used over in the Netherlands to look at muscles, and that's where my PhD is focused on muscle ultrasound, and I'm hoping that it's something that we can start to apply or use in the UK. I've shown you how we can use it as a qualitative evaluation tool. Again, we've got a little pragmatic study going on at Queen Square where we're using a handheld ultrasound machine to look at whether we can make judgments of a binary judgment about vocal cord palsy in our neuro patient group who are also having a nasendoscopy. So we're looking at whether it's those results correlate. So we'll hopefully have some findings in the next few months, or at least in the next 12 months, and then shown you how it could be used and how research is evolving to be using it as a quantitative assessment tool. And I think that's really the area that it needs the most work, because it's really important to make sure the validity and the reliability is there. So there's your overview. I'm going to come back to the Mentimeter. Am I? Yes, I am. Oh, it should still be on your phone, shouldn't it? Haven't got the barcode again, so hopefully you haven't deleted it from your phone. So maybe it will be interesting to see whether your view has changed with that whistle-stop tour of ultrasound. And I will pop that up. And please do just populate the chat. I can't see MS Teams at the moment, so pop any questions or even just comments at this stage about what you think. Have people been able to move on to the next one, or am I just being useless? So they were the first initial results. Are you able to access the second question?
No, Jodie, it's not coming up. It's saying it's already been answered.
Oh, that's sad, isn't it?
Mm.
Oh, I'd done so well as well. Oh no. Okay, maybe I'll fiddle with it while Lee's talking, and we can do a post vote after that.
Jodie, I think you can manage the results if you.
This one?
I think so. Yeah, you can clear your results. Reset. Yeah.
Does that work?
But you might need to share the QR code. I know I shut it down after I used it.
Let me come back to the original one. How's that? Hopefully it will take you to the second question. Any good, gang?
I'm still getting the same question.
Oh no. Okay, well, let me fiddle and see if I can, because I've got 2 on my account, but I'm clearly not as clever as I thought I was. So let me fiddle while Lee does his presentation and see whether I can get it back up on the second question.
Jodie, I'm going to give you options. You can, because you finished a little ahead of schedule, so we could do some questions now.
Yeah.
Or you can have a fiddle and Lee can do his presentation. So I'm going to give you the option.
Oh, you choose. You're the boss. I don't mind.
Well, how about we let you fiddle?
Yeah.
And then we'll get on to Lee, and then we can bring all 4 speakers back, and we can do a bit of question time. I think that'd be quite nice. Carry on fiddling. Lovely to see a side of you we've never seen before, including your muscles and a colour coordinated approach to your presentation.
You're very welcome.
I look forward to seeing you
have a signed copy.
Lee, now you're going to wow us with esophagoscopies, is that correct? Have I said it right?
You have said it right. I don't think I'm going to wow you.
That's a lot of syllables for me at this time of day. Okay. I'm going to let you crack on, and then we'll get all our speakers back at the end of this. Thank you.
Okay. Can you see the screen?
Yeah, we can.
Super. All right. So, well, I mean, yes, I'm Lee Bolton. I'm the clinical lead for adult speech therapy at Brompton and Harefield hospitals. And I promise that Jodie and I haven't conferred on our talks, but actually it's quite nice. I think you're going to see a little bit of sort of overlap in where we are with functional esophagoscopy compared to where we are with ultrasound. So I think, you know, really keep Jodie's mind in talk in mind, because she's done some really great work there in developing that. And also similar to Jodie, I have a couple of questions that I wanted to just to kind of ask for the group. So again, I'm going to stop sharing here, but rather than use Mentimeter, I am going to use Slido, but you're going to get the same thing. If I can work out how to do this, so you should get, that's not going to work, is it? Sorry, let me just stop sharing my screen. That's just showing my main screen, isn't it?
Yeah.
Sorry, let me just fiddle around with technology. Okay, so let's see if this works. If I can bring up the Slido now. And this worked earlier when I did it, so I'm not quite sure why it's working. Not it's working now. Or sorry, guys, I know it's really annoying when people can't get their tech to work.
Don't worry, Lee. We've got time. Don't worry.
I am going to try and do this once more and see.
How about while you get comfortable with that, if Jodie, if you don't mind turning your camera on, do we have any questions for Jodie while it's Lee's turn to have a fiddle with technology?
There's a couple of questions in the chat to Jodie, if that's okay. There's one about salivary gland Botox. So another person has asked which salivary glands you said were injected with Xeomin and why are some not injected? And she was wondering about the pathway that you're setting up at Queen Square as well.
Yeah, so we never inject the sublingual salivary glands because they're not big producers of saliva. They're also quite high risk for any Botox migration, if you imagine where their position is under their tongue. So the Xeomin route regime is the parotid and the submandibular glands. So you get a dose into each of those bilaterally. And yes, we're setting up an ultrasound guided Botox service at Queen Square, which is SLT led, because we have access to Botox at Queen Square by various providers, but it's not necessarily a consistent service. And we think speechies are probably best placed as AHPs to support that service. So we're just developing a clinical guideline now. It went to our clinical governance, safety governance yesterday. So we're developing a guideline on an SLT-led Botox service, which will absolutely be ultrasound guided. Hope that answers the question.
Thanks, Jodie.
Mostly not just because I love ultrasound, but I think just to preempt a question about why ultrasound and not landmark, because the other way to inject Botox is landmark, feeling for the glands. But I think I've seen enough now myself that salivary glands are not always in that beautiful position where you expect them to be. So you might miss them. And certainly if you miss the gland, then your treatment is not going to be effective. It's not necessarily about putting Botox into the wrong, well, it is about putting Botox into the wrong place, but actually it negates your treatment if your patient's travelled all the way to the hospital to be Botox and you miss the gland. So at least with ultrasound, you know that you're getting it into the actual salivary gland.
Now I'm just going to pause you for 1 second, Jodie, before we do any more questions. Lee, Sarah says the Slido link is working.
Oh, okay.
So I don't know if you want to try and get that screen up again, and we'll let Jodie continue to fiddle with Menti.
Okay. Not quite working. So what can you see right now?
We can see the slide
You can see
QR code.
Okay,
Yeah,
that's fine. In which case, go ahead, take a photo of the QR or pop the slido.com code in. Let's just activate the poll. So there's just 3 questions. I just thought it'd be nice to sort of find out from the group where people are joining from. It's like a good spread. Wow. Great, that is a good spread. Excellent. All right. Let's have a look at the next poll. So, oh, still coming through. I'll let people finish typing in. Okay, so next poll then, just sort of asking you which level of competence you're at the moment working out with your RCSL2 fees. Okay, so sort of about 30% not using fees at the moment. And then we've got sort of an even spread of level 1, 2, a bit more 2As, and a reasonable number of level 3s. That's great to see. Okay. Okay, last one. I was just interested to find out how often people are using esophageal screening in their VF clinics. Okay, so that's over a third of people routinely using it. Just over a quarter of people using it sometimes. Yeah, okay. Okay, so pretty much routinely being used by people on the call in their VF clinics, and then sometimes being used as well. Okay, so maybe just keep a kind of a snapshot of that image in your memories for later. All right, I'm going to close this poll and hopefully switch back to my PowerPoint. So let me share that with you. Okay, so you should be able to see the PowerPoint here. All right, so Slido bit done. So thank you for sharing about kind of where you're from. I was just going to give you a little bit of overview about my SLT journey. So I'm a languages graduate from Sheffield originally, and then went on and did the sort of master's conversion course again at Sheffield because I loved it so much there. And then I went on and did a sort of Band 5 preceptorship post at Milton Keynes, which was a fantastic first post. I don't know if there's anyone from MK. I used to work at MK on the call, but yeah, I absolutely loved my time there and think back on it very fondly. And that was a really nice post. I had some mixed acute community experience and some voice, and started video philosophy competencies there as well. And then I moved on to a Band 6 post at Stoke-on-Trent, back up in the Midlands, near kind of where I'm from originally, and again had a sort of a mix of acute and head and neck work, which is one of the reasons that sort of attracted me to that post. Really, it was a split post, acute head and neck and some voice. And then I had a bit of a unexpected stint working overseas in Dubai in a private hospital, and again was just doing some mainly acute critical care and outpatient work. And then I came back from Dubai and moved down to London and started working at Imperial College Healthcare, so Charing Cross and St Mary's and Hammersmith hospitals. And it was kind of whilst I was there, I was doing again a sort of a post moving between acute critical care and sort of head and neck as well. And I sort of started developing a bit of an interest in patients with acute and chronic respiratory disease, and that sort of led me to do or apply for a pre-doctoral fellowship. So I undertook a pre-doctoral fellowship looking at sort of swallowing and acute exacerbation of COPD. And then in November last year, I moved across over to Royal Brompton and Harefield hospitals on part of a secondment opportunity. So that's a bit about me. And I mentioned I was working at Imperial, and when I was working at Imperial, we would obviously sort of, get referred a fairly steady stream of people admitted with acute exacerbation of COPD on the acute units. And our practice has sort of evolved to use fees more often with this population. It was sort of a bit more convenient and quicker to schedule than VF. At the time, we only had sort of access to VF clinic once a week. Fees answered the sort of the immediate clinical question from the referring team, which was mostly around aspiration or aspiration risk, and obviously then avoided sort of having to bring patients back for an outpatient fit of fluoroscopy after they'd been treated for the exacerbation and discharged home. And that obviated then sort of waiting lists and inconvenience for patients to sort of come back to hospital. And obviously those patients no longer being in an acute exacerbation phase, that they've been treated and then they were sort of back at home again. And fees seem to be generally well tolerated by this group of patients. And we'd sort of get some mixed results. So we'd see people who had no dysphagia at all, or maybe some age-related changes in swallow function, maybe a little bit of kind of mild inefficient swallowing, but no significant sort of aspiration risk, all the way through to sort of severe dysphagia and silent aspiration. And we'd be talking to the respiratory medicine consultants about whether we should do a video or whether we should do a FEES as the sort of instrumental assessment, and sort of, we'd be talking about the differences between them and what we'd see. And as many people will know, one of the things about chronic lung disease is that it frequently co-occurs with esophageal dysmotility. And there's a good paper published in Nature Reviews here by Leslie Horton, which I'd recommend reading if you haven't, which talks about sort of impaired esophageal peristalsis and ineffective esophageal motility being very common in this group of patients, more than the other specific motility disorders of distal esophageal spasm or hypercontractility. And I was talking to one of the respiratory consultants one day, so after we'd done a FEES with a patient who'd been referred to us with a medical concern of query aspiration, and I was sort of explaining that there were no signs of oropharyngeal dysphagia, no aspiration, that we'd sort of stress tested this person, we'd asked them to drink sort of rapid swallowing of thin liquids, some straw drinking, we'd given them a fair amount to eat and drink, and gone back to liquids at the end again, hadn't really sort of induced an aspiration risk. But obviously we couldn't say sort of what was happening in the esophagus. And she said, well, can't you just put the scope down and check that it's all gone? And instinctively I said, no, can't do that. It's not part of our FEES procedure or protocol. It's not written into our policy. And she said, well, it would be a lot simpler if you could tell us now that answer, rather than sort of have to bring this patient back or keep them in hospital for longer to have a VF or to have a barium swallow. And I'm no Albert Einstein, but I am curious, and it's sort of this question sort of stayed with me. It really sort of got me thinking, and I went away and had to think about it and had a chat with one of the gastroenterologists, fully expecting him to say, no, absolutely not, you can't do that. But his response was actually one of, well, esophageal dysmotility is a really big problem for us. You know, we're concentrating on cancer and 2-week waits, but there's all these people that get referred with questions about motility disorders, and many of them will have oropharyngeal dysphagia as well as esophageal dysmotility or dysphagia, and we've got limited treatments for it. And he was sort of saying that he'd read somewhere or he'd heard somewhere at a conference that if you swallow hard, you could generate better pressures in the pharynx, and that might help clear some of the residue or some of the bolus through the esophagus. And he was sort of wondering about, you know, that as a potential treatment. And as we talked more, we've kind of talked about, you know, what whether it would be technically possible to do. So we sort of said, well, you know, a nasendoscope is approximately same sort of diameter as a manometry catheter, which is transnasally placed, or an NG tube, which is transnasally placed. And obviously these are also placed into the esophagus in awake, unsedated individuals. Obviously these types of tubes are licensed for this purpose, and even though the insertion method tends to be non-visualized or blind, the people putting them in are trained to do that. And so we also talked about whether there would be enough length on a nasendoscope, a nasopharyngoscope, or a laryngoscope, whatever you call it, to be able to pass it into the esophagus. And his feeling was it would probably be long enough to get to where you needed to be to sort of get a view about whether the bolus had cleared or not. And some of you might know about Edward de Bono's work, the sort of 6 thinking hats, which is sort of a tool for helping people think about things from different perspectives. And sort of up until that point, I suppose, I'd been wearing a black hat, which was the one of caution and being critical and sort of negative in thinking. And the conversations with the respiratory medicine consultant and the gastroenterology consultant had sort of started me thinking, I probably just need to take this hat off for a moment and start thinking about it from some other perspectives. So I started thinking about it creatively and what the possibilities might be, or the benefits, and then also started thinking about, well, what do we know? Are there some facts that we can that I can look at? So, of course, that sort of took me to do a bit of an evidence scan, and it brought up a series of articles. But one of the classic articles here from Bronwyn Jones in 1985, highlighting in the very first line of the abstract that simultaneous disorders of the pharynx and esophagus are so frequent that the complete swallowing chain should be examined in all patients with dysphagia. So again, based on the results from that Slido, with lots of people performing esophageal screening in fluoroscopy clinics, this is something we're all familiar with and we know. And of course, their perspective is one of radiology and fluoroscopy, not endoscopy. And the this study was really looking at patients' accuracy of their symptom localization for dysphagia, and we're going to have a look at those results just in a minute. And then I came across another article which is much later. I think this is sort of around 2020. So this is Jacqueline Allen paper, also emphasizing that swallowing doesn't stop at the piriforms, unless you're very, very dysphagic, and sort of our tendency to sort of compartmentalize swallowing assessment and treatment actually by these anatomical boundaries might not be very helpful. And that's, of course, because, as everybody knows, this is a complex system. It's multi-phase, and it is intertwined and codependent, and there are bidirectional relationships between oral, pharyngeal, esophageal, and lung mechanisms for swallowing. And so what we know about pharyngoesophageal relationships is obviously that this is a pressure gradient system. You've got to be able to generate some pressure somewhere in the system. We also know that oropharyngeal and esophageal dysphagia can co-occur. And we know that there are some pharyngeal behaviours, such as piecemeal transit of the bolus through the oral cavity, which can impact on esophageal motility by deglutative inhibition. We know that symptom localization is poor. We're going to have a look at some data for that in a moment. And we also know that there are some swallowing strategies which might impact on esophageal function. And so this is that data from that Bronwyn Jones paper, using fluoroscopy, not endoscopy. And again, if you look at the yellow box there, you've got patients who are reporting their dysphagia in the level of the neck, but actually have dysphagia in different parts of their lower GI tract, including achalasia and the lower esophageal sphincter. There's some lower esophageal and mid-esophageal strictures there as well. You've got patients that might report their swallowing, difficulty swallowing even higher, but again, actually have referred sensation from strictures which are lower in the esophagus. And then if you look at the sort of the red box there, we've got patients who have identifiable upper esophageal dysphagia because of stricture, but again, they report their sensation lower down, mid or even lower esophageal level. And then we've got a little bit of more data, again, from video fluoroscopy here. This is a sort of analysis of some retrospective data done on outpatients who were reporting a sensation of food sticking in the throat when they swallow. And a table at the bottom there showing the pharynx. So only sort of 8% of people who have a pharyngeal who actually have a restriction in the pharynx, but actually the majority of these people, so these again people who are reporting food sticking in the throat, the majority of them, that green box there, are having esophageal body problems. So this is a problem with either dysmotility or some obstruction to flow in the esophagus itself. And then we've got a bit more data, this time from a sort of a gastroenterology perspective. Again, if we can look at sort of just that end column in table 3, we can see sort of just looking over here, I think, that if the person's ability to report accurate identified dysphagia in the upper pharynx, sort of around 81%. But as soon as the site of the obstruction gets a bit lower, middle or lower, the ability of patients to accurately identify where that's occurring is less than 50%. And their conclusion from this study was really that patients' perceived level of dysphagia is not reliable in determining where the actual breakdown is occurring, and it shouldn't be used to tailor investigations. And they also go on to say that endoscopists and radiologists should be aware of the importance of carefully examining the whole esophagus, regardless of a patient's perceived level of dysphagia. And then most recently, we've got some data from Stevie Marvin in 2020, and again, looking at a prospective study of video fluoroscopy, followed by a barium swallow, and looking at patients' ability to accurately localize where their symptoms are. So some of the data from this study presented here. So the most common sites where patients report stasis is the pharynx, 55%, but actually pharyngeal stasis was the least common finding in this study, only 24%. 29% of patients are localized, only 29% of patients, sorry, localizing their stasis accurately, so very low. And then we've got some other figures there. So 41% of patients who had a functional abnormality on the barium swallow part of the VF. 60% having esophageal abnormality, which was likely to cause esophageal stasis. And then 23% having both a functional and structural esophageal abnormality as well. And then I mentioned earlier that swallowing behaviours can have an impact on esophageal swallowing, and there's just 3 papers about that here. There are others too, looking at how perhaps strategies that we might ask patients to do, such as an effervescent swallow, can have, for example, a positive impact on esophageal peristalsis. But equally, some swallowing manoeuvres, such as the Mendelssohn's manoeuvre, have been suggested that they may actually decrease esophageal peristalsis. So some of the things which we manipulate within the pharynx to improve pharyngeal swallowing might have a positive or negative downstream influence. And of course, in video fluoroscopy, we've got 2 different rating scales available for use that both include scoring for esophageal function and completeness of bolus transit and clearance through the esophagus. So we've got the New Zealand the enzymes here, and the MBS IMP tool at the bottom. And if we look at Jackie Benfield's recent study of SLT practice in the UK in video fluoroscopy clinics, we can see here that some of us are using these scales, MBS and enzymes, as well as sort of local, perhaps more in-house developed scales. And some of the data from that study showed that 50% of people who responded to this survey report scanning the esophagus during VF, and that's over half. And then another quarter scan the esophageal phase only when there are indications. So we've got sort of 3/4 of the study respondents screening the esophagus during fluoroscopy. And again, that's just thinking about the results that you guys put into the Slido recently. That sort of feels fairly consistent, that this is an established part of our practice in VF. So I went sort of back to have a look at the literature to see whether I could see anything about endoscopy and using endoscopy functionally. And there's a small handful of studies which I'm going to talk about now. So 1988, Langmore obviously produced her first description of the FEES procedure, and that doesn't include anything about passing the endoscope into the esophagus or looking at functional esophagoscopy. So it wasn't until 1997 that we have our sort of first description of what these authors call functional pharyngoesophagoscopy. And then a couple of years later, we've got a small study looking at the ability of video endoscopy to evaluate esophageal motility. And then we have a long gap of 10 years before Peter Belawski and Catherine Rees in California describe and give some data on their technique of using GOOSE, which stands for Guided Observation of Swallowing in the Esophagus. And then again, another long gap, 10-year gap, before we've got some phoniatrists in Italy talking about esophageal FEES or EFEES. And then 2021, last year, we've got the German neurology group who use a lot of FEES with their patients, sort of giving again, another description and some more data on functional endoscopy after FEES. So if we have a look at just some of these papers. So this is the first paper, the Herman paper. They're using a slightly longer endoscope, 70 centimeters. So most of our laryngoscopes are probably around sort of 300, 350 millimeters or 35 centimeters. So this is a slightly longer endoscope. They allow sips of liquid to be swallowed to allow the scope to be passed into the esophagus. So that's similar practice for manometry insertion, for NG tube insertions. They go all the way down to the gastroesophageal junction, and then they sort of draw back, and they're evaluating both mucosa and function during bolus swallowing. And they're looking at, for example, peristaltic waves and whether they're visible. Now, this was really a descriptive study of the technique that they use rather than a study of evaluating feasibility or validity. And their conclusion here was that their proposal is that functional pharyngoesophagoscopy could be used as a routine technique in patients with dysphagia problems or with pharyngolaryngeal disturbances that may be related to esophageal disorders. This was that second paper that came just a couple of years afterwards, looking at video endoscopy diagnosis. So these authors are gastroenterologists, and they acknowledge that manometry is the gold standard for diagnosing esophageal motility disorders, but they were interested to see what you could see if video endoscopy could be used to look at esophageal motility disorders. So they didn't use bolus swallows, they used sort of salivary swallows, and they were looking to see whether it was possible to observe what they call lumen-occluding peristaltic contractions in the mid-esophagus, so 25 centimeters, so not all the way down at the bottom. And just some of their data presented here. So it was possible to see these contractions in the majority of control subjects, and conversely, patients that have esophageal dysmotility problems, you don't see them. So only 1 out of 20 patients with achalasia produced this peristaltic contraction that obliterated the esophageal lumen. And again, a small number of patients with scleroderma as well. So their conclusions here again that it is possible to identify signs of esophageal dysmotility using video endoscopy. And then we had that sort of 10-year period before Peter Belaski and Catherine Rees produced their paper where they talk about functional esophagoscopy as an endoscopic evaluation of the esophageal phase of swallowing. And this is just outlined here, sort of their technique as they describe in this paper. So if the patients have a DeFees before in the standard way, and if there's no penetration or aspiration on fees, then the scope is passed into the esophagus and residue is observed. If there's aspiration or penetration during the fees that's happened immediately before, they pass the scope into the esophagus, but they wouldn't give a bolus. So they are looking at the esophageal body. They evaluate the esophageal body, both from the perspective of mucosa and structural abnormalities, but also in terms of whether there's food or fluid remaining in the esophagus after 15 seconds, which they consider abnormal. And then they pass the scope a little bit further to the aortic compression, which is what sort of an area that you see on endoscopy within the esophagus, and they ask the patients to swallow some puree and liquid and cracker, and they look at bolus transit and esophageal motility. And then they go a little bit lower. So again, these guys are using a slightly longer endoscope. They go all the way down to the distal esophagus, just above the gastroesophageal junction. Again, ask the patients to swallow some food and liquids. And they're looking at distal esophageal motility and the bolus passage through the lower esophageal sphincter into the stomach. And then finally, they complete the study by going into the stomach itself. They retroflex the endoscope so that it looks back on the fundus and the gastric cardia. Again, ask the patient to have something to eat and drink, and they visualize the bolus passing into the stomach. And they time how long it takes from the swallow being initiated in the pharynx all the way to seeing the bolus pass into the stomach. So that's sort of the description of their technique. And they compared this with video fluoroscopy and esophageal screening or manometry. So some of their results are presented here. So 71% agreement between this video endoscopy of swallowing versus a VF with esophageal screen in being able to localize the site of dysphagia. 9% of people in this study showing impaired esophageal motility on Goose on the video endoscopy, but not present on the video. Conversely, 18% of patients having some esophageal dysmotility on video fluoroscopy, which wasn't detected on video endoscopy. And then there were a very small number of patients that went on to have a simultaneous video endoscopy plus manometry. And so only 6 patients. And so this is a very small number, but again, there was 83% agreement here between the video endoscopy, the Goose procedure, and manometry. This was the data that then came sort of 10 years later again. So these are the phoniatrists working in Italy, looking at what they call esophageal fees. So doing a fees procedure, and again, then immediately afterwards passing the endoscope into the esophagus. And again, they sort of described their technique of how they do this in 20 patients in an outpatient clinic setting, sort of outline the steps, the parts that they're looking for. So again, they do test with the bolus, and they're looking at different parts of the esophagus, the UES area, the actual esophageal body, and also the lower esophageal sphincter. And they're looking at components of bolus flow and residue and clearing patterns. And then the final study that came out in 2021, so this is the group of neurologists in Germany, again using fees. And the purpose of this paper really acknowledging that functional disorders of the esophagus and the upper esophageal sphincter are often asymptomatic and they can remain undetected. And multiple methods are needed to evaluate swallowing. So they wanted to know sort of whether it is possible, this is part of their feasibility study, to see whether it's possible in practice to directly visualize and evaluate swallowing by developing a functional esophagoscopy to sort of fill a test gap. So they did a prospective observational study, 31 neurological patients. These were mostly Parkinson's disease, but also some atypical Parkinson's in terms of PSP and MSA, and then a sort of small number of neuro patients that included myasthenia gravis and oculopharyngeal muscular dystrophy and some neuropathies, I think. Their primary outcome measure was feasibility. Is it possible to do this? And then their secondary outcome measures were safety and tolerability and comparison of functional esophagoscopy with manometry, so an initial attempt at validity. And they, as part of their methodology, all of their patients had a prior upper GI endoscopy. So anybody with an organic abnormality in the esophagus was excluded. And again, like the previous authors, they used multiple scope positions in the esophagus, and they asked patients to swallow saliva, yogurt, bread, thin liquids, using again both sort of the normal anterior grade view on the endoscope, plus also angling the scope backwards to get a retroflex view. And in their series of patients, their results then, no adverse events, so suggesting that their technique was safe. But there were some discrepant findings between the FEES, the functional esophagoscopy, and manometry. And that may have been due to some methodological problems in the rating scales that they used, as well as the difficulties in comparing different levels within the esophagus. There were some unique findings as well. So it was possible to identify impaired clearance from the esophagus, and specifically incomplete or delayed closure of the UES and the lower esophageal sphincter. They were able to also pick up hyper and hypotonic UES and LOS, and also different types of clearance abnormalities, including hyperperistalsis and hypomotility. And in their case series here, so 72% showing an esophageal dysfunction using this functional technique. Limitations, obviously this was only a neurological population. They didn't present any data about the bolus clearance patterns, and unlike the Goose study previously, also didn't use a timing measure. So we need to be careful, and this is sort of where the black hat thinking comes in and is very useful. So we need to think about what else we might see. So it's very common to see anatomical abnormalities in the esophagus using endoscopy. So 65% are in the Italian paper, Farnetti and Genovese paper, and a higher incidence, 71% in the Belasky and Rees paper. And the things that they are reporting are hiatus hernia, esophagitis, which might be due to sort of pill-induced or reflux-induced, diverticulars, strictures, reflux, and cancer. And of course, we are used to seeing mucosal, structural, anatomical changes on FEES. It's not something new when we put an endoscope into the pharynx and larynx. And there's a nice paper here, again, looking at patients who have been discharged from an acute care setting, the majority of whom have been intubated, and then had gone on to a community setting. And this sort of paper here presenting their data on over a third of patients who had laryngeal pathology, which was identified only on the FEES. And we also need to think about where this fits. So there are already existing esophageal imaging studies. So where does esophagoscopy fit within that? We've got sort of more structural, anatomical, mucosal based imaging studies. So that would be our OGDs and TNOs, transnasal esophagoscopy. And they tend to be performed by our medical colleagues, so gastroenterology and ENT, but rarely, if ever, have a functional component to evaluating swallowing in the esophagus. And then on the other side, we've got our more functional tests. So we've got high-res manometry with impedance, barium swallow, and video fluoroscopy with an esophageal screen. Of course, the latter two involving ionizing radiation, and of course we need to be very careful about our use of that. And high-res manometry, which is particularly good for contractility and physiology and motility. So again, just sort of starting to think about where does a functional esophagoscopy or video endoscopy fit within this. So where are we? So unlike sort of in what you heard from Jodie, I think at the moment we're very much in the beginning stage of this. So there's a number of considerations which we're thinking about at the moment. I think we can say that functional esophagoscopy by SLTs is not ready for widespread clinical adoption at this point, but it might be possible to introduce it as an assessment method into clinical practice in certain centres, providing that approvals and mitigations are met. And so in thinking about that, we submitted a paper to our local clinical practice committee, which is our organisational governance committee, to ask for permission to use this technique to pass the nasendoscope into the esophagus to look for clearance of the bolus through the esophagus. And that was presented to a panel which included the sort of medical director and the chief nurse, risk managers, and then a group of clinicians involving ITU clinicians and respiratory medicine and cardiothoracic surgeons, because that's the sort of organisation that I'm currently working in. And that has been approved. So we sort of have approval to for us to use that within the local, within our organisation. And so at the moment, we're also in parallel then having discussions with RCSLT, specifically around sort of the professional indemnity for this. Obviously, this will be extended scope of practice, and we want to make sure that we are covered for doing this. So Tom at the Professional Inquiries Office is helping us with having conversations with the insurers about that. And then we need to think about the use of equipment for this purpose. So nasopharyngoscopes, as they're called, are not necessarily intended for this purpose, but actually recently there's been a reclassification of the endoscopes that we use, which are the Xion scopes, to make them class 1 devices from just a couple of days ago. And with that, there's the possibility that the scopes could be used for different practices, different purposes. And then, of course, as we saw, there's a high incidence of abnormalities identified on during esophagoscopy. So we need to have a really clear, robust process in place for gastroenterology image review. And then we need to think about evidence, and that can of course come from different places. So it may be that if we get all our permissions and all our ducks in order to begin using this, then some evidence will come from practice. So we'll have some practice informed evidence, and that will of course generate and drive some questions and hypotheses that then might go on to become research questions in the future. So that's sort of where we are. And yeah, happy to take any questions.
Thank you, Lee. That was really interesting, really interesting. I think it's been a really interesting morning / afternoon. Can I ask all of our 4 speakers to put their cameras back on, because I have a list of questions to be asking you all, please. In fact, just before we do questions, Jodie, I believe Mentimeter may have finally worked for you. Would you like to do a final Mentimeter?
I don't make any promises, but what I've done with my technical skill is create 2 Mentimeters with 1 question in each. How innovative is that? So what you're going to have is momentary amnesia as you respond to the first question, like you haven't seen the presentation, and then we'll move on to the second one. How great's that? So bear with.
I can't wait.
Bear with. So here we go.
The anticipation is real.
Here is the first QR code. Hopefully that will take you to a single question Mentimeter. And then when everybody has done that, you can go on to the second QR code. Remember that you've seen the presentation, and then go to the second QR code and answer that one. And then, Alexi, you can create some sort of musical interlude while I work out where to find the results.
Nobody. and I mean nobody, wants me to do anything with music for the purposes of this forum. But I think if you go to your Safari bit now, we'd have the answer, won't we?
Right.
I remember for your initial answers, 2 were sold before your presentation.
I know, but I wiped it, didn't I? So everyone's had to pretend. Here we go. So here's the, oh no, I've not shared my screen. Oh,
Yeah,
blimey. Oh dear. Right, hang on. Here we go. So here's the first Mentimeter. And then the second one is, I mean, I haven't got a side-by-side comparison. That's one step too far. Here's the second one. I'll put them next to each other in the presentation, and then we'll have a side-by-side comparison. But that's very useful just to get a bit of a ready reckoner for me. So thank you for bearing with my technical inabilities.
You're very welcome. Whilst you're making your presentation, your side-by-side, Anna and Emma, I'm going to ask you the first question. Can you talk us through a bit more about when you use instrumental assessment in lymphoma, when FEES might be helpful versus VF as an initial assessment?
Yeah, so I guess, sorry, so I guess it's not necessarily just lymphoma, but I think this patient was a good example of the hematology patients presenting with CNS infiltration. So they're both useful tools. What I would say is I probably would have done both with this patient as an initial assessment, or because they both had benefits for him. I think his vocal cord palsy, his secretion management, would have kind of led me to do a FEES, and also that kind of nerve infiltration as well. But also the video is very helpful in terms of seeing kind of gross amount of aspiration, and then also where he quite clearly had upper esophageal issues. And I think if Lee probably would have like stuck a scope down him as well, down into the esophagus at the same time. So both are very useful in this population, and I think again it's linking back to what are you looking for from your cranial nerve involvement.
Excellent, thank you. What about, can you talk a little bit more about using the effortful swallow with sterile water as therapy, and what led to your decision making, and did you limit the bolus size?
Yeah, so the sterile water was trying to add on some actual oral intake for the swallowing, so we weren't just focusing on non-swallowing exercises, if that makes sense. So adding to our repertoire of what we were doing. It also really helps the patient's mood. You know, I think we've always talk about the evidence base, but purely also for the patient, the fact that he was finally able to have water, albeit sterile, it was a motivating factor for him to continue with the therapy. So yeah, like I said, I took a McNeil type approach. So we started off just with 5 ml of sterile water, and then we increased that to 10 ml, and then we increased it to kind of him filling his cap of the sterile. He had sterile water because of the NJ, so he kind of just filled the cap, and then, you know, there is only so far you can go because it has to stay functional. A patient's not gonna on purpose fill their mouth with water to really challenge their swallow. But I did talk to him about whether he would, as a baseline, take consecutive swallows, which he said he wouldn't. But I think it's something that we could explore a bit more. But essentially, it was just that hierarchy of 5 ml, 10 ml, and then an increase, like a large bolus where you might accidentally fill your mouth a bit too much, and then now potentially going on to consecutive sips as well.
Thank you. Another for you, Anna. How do you think the dysphagia rehab should have played a role in the acute phase of this patient's recovery, particularly the non-swallowing exercises?
Yeah, so I guess my theory behind that was linking the rehab back to what I saw in VF. So in terms of the Masako, his tongue base retraction was quite poor. And then it was a bit of a domino effect in terms of what was happening with his residue. So I just kind of really mapped them like that with doing the Shakir and the Masako with what impairments I was seeing on VF in terms of his pharyngeal stage was very weak as well. And then the lax Vox therapy was more so he could get kind of gentle voice onset. And again, working through that hierarchy from the vocal cord palsy perspective as well.
Brilliant, thank you. Jodie, some questions for you, please. Where is the ultrasound probe placed to look at the vocal cord? Can you demonstrate on your own throat, please?
Yes, can you see me? So here's my probe. So that's the end of the probe. And basically the image that I had earlier to look at the floor of mouth muscles, which goes across the jawline, if you sweep down, we call it a laryngeal sweep with ultrasound. So you sweep down, you look at the floor of mouth muscles, you then pass the epiglottis, and then basically when you hit the laryngeal cartilages, most of the laryngeal cartilages will not allow the sound waves to pass through, so it's darkness, so you won't see anything. So you have to get your probe between what we call the laryngeal windows. So it either goes between the hyoid and the thyroid, or between the thyroid and the cricoid. So you have to get a window, and there's no real definitive as to which one will give you the best window. It depends on your anatomy and all sorts of things. And actually, some people you can't get an image at all for various reasons. Particularly older males, we find. So yeah, a short answer to the question would have been there.
Thank you. I liked the detail, it was helpful. Some more on ultrasound for you. What do you think the application of ultrasound could be for trachea weaning?
What do we think the implication of ultrasound is for trachea weaning? Ooh, now then, let me have a little think. Trachea weaning. I guess the question is, what do you want to know about trachea weaning? If you're looking at things like secretions, you're not going to see that on ultrasound. If you're looking at cord, airway, patency, you may or may not see that on ultrasound. I guess you may be able to see cord movement. You might be able to identify cord palsy. We're not sure that you can see edema and gross structural lesions, and that's one of the things we're looking at with our kind of smaller research study at Queen Square, is looking at the nasendoscopy images and the ultrasound images to see what can you truly see on ultrasound that might help us advance our practice in more complicated areas like trachea weaning. Like I said, Helen Newman's looking at using ultrasound to look at tracheal size, but then once you put a piece of plastic in the airway, you're riddled with all sorts of challenges potentially about the sound waves getting to the area you want to look at.
Really helpful, thank you. Do you think you could see tracheomalacia on ultrasound?
If you can see the tracheal rings, I say never. I couldn't give you a definitive, but I think there's a possibility. And I think the pediatric study actually, Mary Vivers led the pediatric systematic review that I was involved with, and I'm sure one of the studies in there looked at pediatric tracheomalacia. So if anyone's interested in that particularly, pull her study out and have a look at the paper that used it there.
Brilliant. And I'm interested in the framework you were discussing earlier. So can you tell us more about it, when it'll be released, if there's going to be training on it, what's its purpose? That would be really helpful.
Yeah, so I guess the framework we put together was a very deliberate decision to do it, because we were quite rightly getting lots of very astute questions from speech and language therapists, many of whom might be on the call today, about what's the state of play, where do we go, how do we get trained, etc., etc. And I think we have to be very careful about balancing what we know about ultrasound with advancing practice, and where it's cart and horse, all of those things. And I think we were keen to not RCSLT have supported us putting a statement out during COVID about not using ultrasound for assessment of swallowing and airway function. And I think there's only so long you can sit and make a statement about holding back something. And I think rolling something out in a very measured way and supporting people to understand the utility of ultrasound, play a little bit with the equipment, so that as the research evolves, and some of it is already there to support our practice, we develop that framework. It's actually based on a physio framework that they used for lung ultrasound and various other frameworks. So we basically borrowed the idea from physio. One of the authors is a physio. So the framework is basically a structured approach as to how we might use it in the profession based on current research. So we're hoping, for anyone who's interested, it will be published in the Ultrasound Journal in the next, hopefully, couple of weeks. And RCSLT have endorsed it, so we're going to share a little bit more about the framework when it's launched, so that people can zoom in and find out a bit more if it's relevant and useful to their practice.
Right, thank you. That was really good. Lee, it's your question time now. What is your opinion on esophageal screening use in video fluoroscopy, and should it be a routine part of the assessment?
I think it's useful. We do use it a lot with our patient group during video, and it does feel useful. There are findings that we get from that that we probably would miss if we didn't do it and we only looked at the pharynx. So I think it adds value as part of a video fluoroscopy procedure. But yeah, I'm keen to hear other people's thoughts about that.
Okay. What pathway do you have set up for esophageal screening at present, and do you refer on it if suspecting esophageal dysphagia contributing to a patient's presentation?
So at the moment, we don't have a pathway, so we're not using this tool in our clinical practice at the moment. What we're trying to do, I suppose, is a bit like Jodie, we're at the very beginning stages of working out where the getting approvals and checking that we are okay to do this in terms of extended scope. So we're not sort of using this in routine clinical practice. But a bit like sort of Jodie was saying, at some point we do need to move forwards and think about incorporating it into practice to then work out whether it has legs and whether it sort of can become something. So that's where we are at the moment. It's very, very kind of early initial stages of getting all the governance in place.
Yeah, but I think early stages are the start of something big. It's like a snowball, right? You start somewhere.
Yeah, you have to start somewhere. Yeah, and it's impossible to know where it will go. I mean, that's why it was so interesting listening to sort of Jodie's journey about the ultrasounds and sort of that use, and does this have legs, and what does it tell us, and all those questions that you have. And at some point you do need to have a look at something, and then that will tell you what the questions are that then need to be researched later down the line.
Yeah, absolutely. We had one question. It can be difficult to gain training and confidence interpretation of esophageal screening. Do you think it's enough to say normal, abnormal, or do you think it is within SLT's role to comment further?
Yeah, I mean, these are all great questions, and some of these are sort of research questions, and I absolutely don't have the answer to these questions right now. As I said, I don't know. I think there are perhaps some things that we can pull out of the studies that have been done about whether we would expect to see bolus within the esophagus after a certain time frame. So the thinking in my head is that we would describe that qualitatively and say there was bolus remaining in the esophagus after 15 seconds or after the swallow. And then, of course, it's a discussion with your referring medical colleagues about what the interpretation of that might be and what the next steps of that might be afterwards.
Absolutely. I think sometimes the virtual world limits us to having a real conversation about this, which is why I'm keen for our next send to be in person. Mm-hmm. How do you prevent the scope getting gunked up? I'm sure someone's wrote that just so I get to say that word on camera. Gunked up in the esophagus, and do you look at the end of the fees?
So again, because we're not at the stage of passing it, I mean, I've passed it sort of into me as a healthy person, or had it passed into me as a healthy person, and the scope does get gunked. And you know, I think we all have that experience, don't we, on fees, or sometimes the scope getting gunked by secretions or stuff in the pharynx, and you have to try and find a way to ungunk it. So those are exactly the things that will need to be worked out. If all you see is a gunky image of the esophagus with a whole load of residue attached into the scope, then this is probably not going to have legs, and you're not going to see anything from a functional perspective. But I think that's yet to be determined.
And just following up on that question, so from a personal perspective, how was it swallowing a scope down from an esophagoscopy perspective?
So I had it just as a nasopharyngoscope, so just the laryngoscopes that you would use, and you know, took a few sips of water, and when I swallowed, the person just advanced the scope until it can go no further. I mean, that's one of the nice things about a laryngoscope, is that it's a certain length. It can't go any lower than, you know, your nostril. But it did give a nice image at about sort of 25 centimeters at the level of the aortic indentation in the esophagus. You see some contractility, and sometimes that's all you see for a very long period of time, is just the esophagus contracting. So again, I don't know whether the sort of value of it, but it wasn't sort of uncomfortable. And I know, you know, people that have sort of manometry catheters passed and have NG tubes passed. And these are sort of, again, 3.5, 3.8 millimeter tubes or less. Those can be tolerated in some people particularly well, even awake and sedated, and in other people they're very sensitive. So again, I think that's something that will come out of practice and research.
Yeah, absolutely. I think this one's similar to what I've been asking, obviously, because you're saying it's at the very early stages. But are you proposing to do esophagoscopy alongside pH manometry or other techniques?
No, well, I hadn't thought about that. So again, you know, what we're sort of looking for is approval to just pass the endoscope into the esophagus at the end of the FEES examination. And so we're not looking to sort of compare that with other studies or impedance or high-res manometry. I think that would be a very interesting question for the future for a research study about what does it show compared to those gold standard tests. But at the moment, no, we're not looking to incorporate that.
Brilliant. I'm going to ask my committee colleagues, because they very helpfully compiled those questions for me. Whilst we have been asking those questions, have there any more questions come in to our panel?
Hi, so we've had a couple more, one for Jodie. Are you aware of any work looking at the impact of radiotherapy on swallowing musculature?
Yes. So if you yes, there's a little bit of work where they've looked at the impact of the fibrosed muscle, and I cannot recall the paper off the top of my head because it's not one of my patient groups, but yes, there is. And if you email me, and if you can't find it on online, drop me an email and I will send you the link. There's probably a handful, or at least know of one or two.
And then Lee or anybody, there's been a couple of questions about esophageal screening, mainly in video fluoroscopy, and how you get around it if patients have got poor mobility, if they're frail, if they're unable to stand. Just wonders if you had any comment.
Yeah, I mean, if people can't do it, they can't do it, and you know, that's just the way it is, isn't it? You just have to adapt in clinic. So that's the very reason why we don't and can't do with everybody. If there are limitations in frailty or ability to stand, exactly those reasons, and sometimes it's just not possible. So.
Thank you. And then there was somebody else who was just asking about who interprets esophageal screening. I think a couple of people have replied, but if you do have any experience in your area, maybe you could reply in the chat as well. I think that's about it. Oh, there was one more again for you, Lee, and you may have already answered this. Did you come up against any barriers to approval at all of your study?
So yeah, we took this to, so we, I wrote sort of a paper for our, as I said, clinical practice committee, and submitted that really. That's the process within our organisation for getting sign off for any new intervention that takes place, and that's not just for AHPs or therapists, but for sort of all the medics as well. So that goes to that committee, and that's a broad spread committee, and they ask questions about that, and it gets discussed and sort of debated, and that was the main approval process, really. The first step of the approval process. As I said, we were sort of doing this, or I have been doing this in parallel with putting an inquiry into Professional Inquiries Office at RCSLT about that. So, and the main barrier, of course, is going to be around what you see in terms of both the structural anatomical changes that you might come across, that your view might be present on endoscopy, and what then is going to happen in terms of how those are going to be flagged up, reviewed, what happens in terms of onward referral. And then also just in terms of, well, if you do see bolus within the esophagus, what does it mean? And again, I can sort of see a few comments on the chat about that as well. So yeah, and I think we are, being honest, I think we are sort of in a place of being between asking for approval to bring something into clinical practice by a speech and language therapist that hasn't been done. And then not sort of having the research to support it in terms of the reliability, validity, and what it means. So, but yeah, I think I think there is a need to sort of be innovative and to sort of think about what the potential might be, and then yes, to sort of be very careful and measured and cautious about how that can be implemented in a controlled way in a clinical environment, and see what happens.
I think a question for both Jodie and Lee. From a consent perspective, are you going to be doing your objective assessments with consent to do the assessment, or consent to do the assessment and use it for possible research? What do you think?
So for me, Jodie, do you want to go first, Jodie, or no? So I mean, for me, we're sort of not at that stage yet, because I don't yet have all the approvals in place. So if all those approvals come back, we're sort of still waiting to hear back from the insurers, from RCSLT, about extended scope of practice. Then if we sort of have approvals in place, and the training is in place to be able to detect problems, and the pathways in place to be able to review, then we'll move on to thinking about how we would consent patients. So we wouldn't be consenting them for research, because this wouldn't be a research study. We would be consenting them for what we then consider within our organisation to be a standard practice. And so we, in the same way that we have fees as a standard practice within our organisation, we sort of consent them in the same way. That's the sort of the thought process at the moment, but there may be other comments that sort of come back about that will change and shape that as we go forwards.
Jodie?
Yeah, I kind of echo what Lee's saying. I think for our ultrasound work at Queen Square at the moment, it's all gone through research ethics. So because we don't understand the utility of it for that purpose, so the laryngeal ultrasound has gone through an ethics review process, and it's being used as a research tool. And there's a question, isn't there? When do you make that leap between it from that into it being a standard part of clinical practice? And I think with the muscle ultrasound work, again, that's going to be under ethics for the purpose of my PhD, but actually they are using it clinically in the Netherlands. So I've got a big question mark over my head as to whether, at what point do we introduce that into our centre as a standard clinical tool for muscle patients. So, but at the moment, everything is sitting under a research pathway.
Brilliant, thank you. I think that concludes our questions, apart from one, which is for everyone, which is, would you be happy to share your slides with the people who've attended today?
Oh.
Yeah, that would be fabulous, thank you. I love running this then, because I always think we talk about the most fascinating topics, and what a great career speech therapy is to be in. We're pioneers in lots of ways. So I thank you for everyone's contribution today to some brilliant topics, great case study, two really innovative ways of objectively assessing what the future of speech therapy could be. So I think it's been fascinating, and I'm gutted that you're not in a room where you can hear lots of people giving you a round of applause. But I'll do it for everyone else. So congratulations, everyone. I thought you were fantastic. If there is nothing from anyone else, I'm gonna let you all go. Thank you so much for joining us today. Thank you to the committee for helping us set this up. Thank you to the speakers for being brilliant. Jodie, thank you for going the extra mile and colour coordinating with your presentation. You've all been amazing. Thank you so much. Have lovely afternoons, guys. Hope to see you next year on site.
Bye bye.